Okay, so good afternoon everybody. So the topic given to me is the axillary block PNS guided. So next 10 minutes I am going to talk about this topic. So before that, just I am going to disorder, you have to contraindicate in those situations. Its functional anatomy is very important. In the cadaveric anatomy, you have to visualize the 3D anatomy so that the directions of the needle reposition or needle direction is very important for that. In this case, if you see once you reflect the pectoralis major and the coracobrachialis muscles, we are seeing the axillary at the artery at the center. And the median nerve lies lateral to the axillary artery. Ulnar nerve is more medial between the axillary artery and the vein. If you see the radial nerve, it is much more posterior. That's why the target of this nerve is basically the deeper one. Musculocutaneous nerve is basically exit from your sheath and pierce the coracobrachialis and continue later on. Apart from this, it is not a normal everything. In this case, there are certain variations. This is most commonly that you saw that median ulnar nerve radial nerve distribution. However, certain variations are still there that might cause the technical failure. As in this case, you can see the radial nerve or the ulnar radial nerve there lie away from the axillary artery or some variation that might be. In that case, ultrasound take the upper hand. Very small gauge needle for the local nasal infiltration. You can take a 5 to 8 centimeter short beveled stimuloplex needle is needed for this. Peripheral nerve stimulator, sterile gloves and marking pen. Sometimes you have to mark the area. But make sure inform consent, ASA monitoring, confirm the site of the block, and the last kit is very important. So let's come to the landmark and the positioning. In this case, if you see the arm is abducted to the 90 degree and forearm is flexed, resting very comfortably. And if you just take the marking pen and try to mark a different part, avoid excessive abduction sometimes because axillary artery pulse palpation might be difficult. And also it might make it the brachial plexus nerve superficial, so the chances of penetration is there. So we have to mark the pectoralis major muscles which are palpate that. You can mark the triceps muscle in this way. You can mark the coracobrachialis and the brachialis biceps muscle that you can palpate. Then the axillary artery just below the coracobrachialis muscles, and these are the 2 points of injection basically that normally you do. The upper one is for the median and the musculocutaneous nerve, and the lower is basically the radial nerve, the second injection that you can this. So in this case, as you see, you can palpate the auric of the pectoralis major muscles, coracobrachialis, triceps in this case, and then subsequently do the injection. The first injection that normally you do is the median nerve. So for this you basically palpate your axillary artery, and the needle is punctured over just above the artery. You need a stimiplex needle and increase the current slowly after skin infiltration or skin puncture to 1 and 1.5 milliampere. You need 1 to 2 hertz or just setting up the PNS. And once you can slowly just going towards your around 15 to 30 degree, cranially you can see a slowly wrist flexion and the pronation. So in this case you can take that response. So once you see this case, once you put your needle just above the artery, slowly you can see, and gradually you can just increase the current till you just get the stimulation of the wrist flexion. You can see the pronation movement. This basically differentiates from the ulnar nerve. So if it is a wrist flexion and pronation and the finger flexion, that means most likely you are in the median nerve. Then slowly decrease the current so that there is no response or no motor response below your 0.5 or 0.3 milliampere, and then you deposit the drug after aspiration. Again withdraw the needle bit off and then target the needle toward the ipsilateral shoulder basically at around 30 degree or 45 degree. In that case you have to just look for the biceps contractions. Once you get the biceps contraction, you can redirect oblique, just deposit 5 to 8 ml of drug at this position. Next important nerve is the radial nerve. Basically this is another important nerve, and for this case you have to withdraw the needle, insert the below the artery. So you have to palpate the artery and just insert the needle below the artery and then look for the contractions. So sometimes it might be the triceps contraction the first to occur because it might be encounter the muscular branches or to the nerve to the triceps. So if you're getting a triceps, basically you should not accept this response. Rather you just redirect your needle more deeper and try to look for the wrist and finger extension. So this response should be accepted, and then slowly decrease the current and then deposit around 8 to 10 ml of local anesthetic at this area. Then you are going to look for your third nerve, that is ulnar nerve. So normally ulnar nerve separate injection is not needed. First injection basically when you deposit a median nerve, it partially blocks the ulnar nerve. and then when you start going to stimulate the ulnar nerve, it might not be able to get the stimulant nerve, the ulnar nerve, and then the stimulation of the radial nerve it's all that is only important, or that is very important. As per the CN colleague, you can see 2 separate injections below the artery, it doesn't increase the success. So only 1 injection is important. However, if you encounter such response, that is thumb adduction because of flexocarpi ulnaris or last 2 finger flexion might be, so that might be you are stimulating the ulnar nerve. So in this case again you have to go more deeper and look for the radial nerve stimulation. So still you are having some troubleshoot whenever doing axillary block, you have to just prepare yourself. It might be first, that might be a direct muscle stimulation. In that case it might be too superior or inferior. It might be touching a bone, or that is touching humerus, so that might be too deep, so it draw and redirect. If you are getting a twitch of the hand, that is might be exactly right, so you have to just adjust your current. If you are getting arterial punctures, then in that case it's better to go for the transarterial technique. That means you just deposit half of the drug posterior to the artery and then come back and deposit anterior to the artery. Again, any procedure is not about any complications. Always there is certain complications possible. That might be vascular puncture, axillary vein and artery is there, so you may just apply form pressure. Intravascular LED position you can avoid by carefully aspirate, frequent aspiration. We have to be careful in elderly or frail patient to have the maximum dose. Last can occur. Hematoma can occur because of if you are doing a multiple insertion. Might be nerve injuries can occur if your injection pressure is very high. So always try to keep your current, at least look for the motor response. When there is motor response is below 0.2 or 0.3, that means withdraw the needle. Never inject the local anesthetic when there is a pain or the patient complains of pain, there is abnormal resistance or high opening pressures, and always keep palpating the hand stable when your arterial can be just fix the artery, and so that needling can be more easier. So I think this is from my side. Thank you very much.